Hi everyone. We're going to try and go through mitral valve prolapse today. So I specifically chose mitral valve prolapse because I think it makes assessment of mitral regurgitation challenging. And again, it's a question that we'd love to ask in the exam somewhere. You know, they're going to ask you about assessing either the aortic valve or the mitral valve at some stage, right? And for either of them, they'll often be asking about the difficulties in assessing it. So before we specifically go on to mitral valve prolapse, let's just talk a little bit about assessment of mitral valve regurgitation, how we do it, and the problems therein. So, who wants to kick it off? Why don't we start with this end? We've got Vishal as one of our Echo Fellows here. So, we're going to split this up into, so this is just mitral valve regurgitation. So we're going to have 2D color, pulse wave Doppler assessment, and continuous wave Doppler assessment. And what I want you guys to help me out, we're going to talk through so first of all, just be the method, or I would say findings, or whatever you're going to look at, and the problems with those. So again, something like this is going to come up in the exam. So let's start off. So give us, what 2D findings are we looking for to help us assess mitral valve regurgitation?
So first thing, you know, we may find some pathology like in terms of mitral valve prolapse. So,
beautiful.
Flail.
And why is that going to help us in terms of what we're doing? So if someone's talking about assessment of, you know, how do you assess it? Absolutely, we're going to talk about the mitral valve, and then we'll also say, why don't we say the mitral valve apparatus? I think those are two things. How does that help you assess your mitral valve regurgitation?
So first thing, it will tell me whether it's a central or eccentric.
Cool.
And depending on it's ascending towards anterior posterior, it may give me whether which anterior posterior valve is prolapse.
Nice. And I'm just talking about mitral valve regurgitation, not specifically mitral valve prolapse. It's going to leave it
central or eccentric.
Yep.
And that will may tell the severity as well.
Yep.
And also the effect of the pressure effect of the the regurg on the 2D. So basically, if there's left atrial will get enlarged and all those things.
Nice.
So hemodynamic effect of MR.
Yeah. Anything else going to go up other than the left atrium?
So later on, even so there would be effect on the pulmonary hypertension will lead to depending on the
2D. Yes, stick with 2D for the moment.
Right heart enlargement. And,
okay.
Well, failure.
Yeah, okay. No, not at the moment. So I don't think right heart's going to come into this. I think if you've got severe mitral valve regurgitation, I think it's more going to be affecting the left side of the heart than the right side of the heart. So let's just stick with the big things first of all. Beautiful. So the left atrium is going to be big. The LVs can dilate. Okay. Yep. Anything else? Ejection fraction, LV systolic function. What do you think about the LV systolic function?
Well, that's going to be pulse wave, isn't it?
No.
Oh, you're talking about
ejection fraction.
Will be increased.
Nice. Why is it going to be increased? So this is, I guess this is going to come into the exam technique a little bit, because I completely agree, but most people don't say that in the exam. They say it goes down. Because LV infraction is going to increase at the beginning, right, as it's compensating for it. So I guess we're talking about how to assess the severity of mitral regurgitation. And that's what I mean. You've got to mention in your 2D, we're going to look at the mitral valve, we're going to look at the apparatus, we're going to look at the left atrial size, LV size, and the LV ejection fraction. Beautiful. And what I want us to go to the next bit is, I guess, how are you going to use those findings to assess the mitral valve? So who said increase?
Like that when LV is not dysfunctional, it's going to increase because there are two outlets for left ventricular. But as the LV dysfunction creeps in, ultimately it will come down in a chronicity, in a chronic state.
Yeah, nice. So I think these things are going to help tell you about, yes, severity and chronicity, as you were saying. So first of all, if you see a mitral valve prolapse and a big bloody great hole that's sitting there for the regurgitation, that's got to help you figure out that it's severe, right? If you can see a big hole on 2D, you're probably dealing with a more significant mitral valve regurgitation. If you're seeing a big left atrium or a left ventricle, that's probably going to tell you that it's a bit more chronic. If you're seeing an increased ejection fraction, that again might be able to start telling you that the regurg, there's a compensatory something going on, which would point you away from thinking that we were dealing with mild regurgitation. So I think all of these 2D findings can help tell you, can help guide your assessment of some of the rest of it in terms of central versus eccentric. It can help tell you whether you're dealing with something that's severe, and it can help tell you acute versus chronic.
Annular calcification as well.
Nice, yeah, absolutely, in the mitral valve apparatus. So what are we assessing for in the mitral valve? You're saying about prolapse, yeah?
So basically, as you said, mitral valve and mitral valve apparatus.
Yeah.
Sometimes it's just a central dilation. You can see the annular, the diameter. If it's a big, then make a it's dilation. If it's a prolapse, depending on, because what we are looking at, then we can make out which part of the valve is prolapse.
Nice.
And so depending on if it's obvious prolapse, we can work it out whether it's eccentric MR or it's
very nice. And I think just again the prolapse. So if that's the normal mitral valve, a mitral valve prolapse goes like that. Mitral valve flail goes like that. But on both of them, the jet goes in the opposite direction. So both for prolapse, sorry if I'm doing the dance right, but yeah, prolapse, jet going that way, flail, jet going that way. Cool. Nice.
That would also imply if you have what appears to be a normal mitral valve, but you have a dilated left ventricle with a dilated mitral annulus, then that will tell you that it was functional and secondary rather than primary.
Sorry, can you say that one more time?
So if it's regurgitation, it's either primary or secondary, according to the Carpentier.
Yeah, do you mean primary as in caused by the mitral valve,
About
secondary via dilatation? Yeah.
So if it looked normal, plus you had annulus dilatation and you had a poor left ventricle, then that would imply that it was going to be secondary.
Yeah, absolutely. And I think we just need to have I think secondaries, there are multiple things that can cause your LV to be down. I think you can say that the MR will be contributing to that in some way. I guess what I'm trying to say is it's just MR that we're trying to assess. Mitral valve regurgitation, as it gets more severe, your ejection fraction will go up to begin with as a compensatory mechanism because you've got two holes, as you were saying, coming out of the left ventricle. So, a nice thing might be able to say a normal ejection fraction in someone who's got significant MR is not a normal finding. If you've got a normal ejection fraction, that could be because you're on the downward slope. Does that make sense? So if you're looking at ejection fraction versus severity of MR, so if that's the MR severity and that's ejection fraction, and that's the normal band in there, it's going to go up before it goes down in terms of compensating for it because you're pushing blood out of two holes. So you've got to try and figure out which part of the curve you're on with MR. So just because it's normal doesn't mean you're not on the bad side of it. Okay. So what are the problems with this? Where are we up to? Team, tell me, so what are the problems with some of this 2D assessment for mitral regurg?
So it may not be that accurate.
Yeah.
It won't allow for quantification.
Nice.
It's just answering few questions, but it's not answering the hemodynamic assessment question.
Yeah.
And
pretty good. Subjective and lax qualification, yeah. Can help guide us. Well, let's say it's a guide. Oh, yeah, I like it. Nice. Who's next? Lewis McLean. Hi. I think we've only got one Lewis on here, don't we? Who else is it?
There you go.
Hi, guys. How you going, man? How's oh, sorry, you do have Lewis Campbell here. So yeah, Lewis McLean. How's Fiji?
Rainy today.
Oh, my heart bleeds. Terrible. I'm stuck in the mountains. It's nice. It's not too bad here either, to be honest. Color Doppler. So how are you going to use color Doppler to assess severity of MR?
Yeah, so it's so color Doppler's a large part of assessing the severity of MR. Okay. It gives you the jet characteristics, so whether it is a central or eccentric jet. So the characteristics speak to the mechanism. And
why do you care about that?
So it helps you put together the picture of the pathological process that's causing it.
Cool.
And it also helps you grade the severity. So eccentric jets being more difficult to quantify with color Doppler and more likely severe.
Why?
Because you're going to have blood going all over the place and it's difficult to see exactly what's going where.
Not with the eccentric one, you don't? I'm looking for a buzzword. There's a buzzword in there.
Wall hugging jet.
Yeah, nice. Yeah. That's the eccentric bit, the wall hugging jet. And it's the Coanda effect. Do you remember what's about?
Oh, yes. I do. I do remember reading about it, and I do remember thinking that was important.
I'm not an engineer. But I think the Coanda effect.
Fluid down the drain.
No, I've got it more as what makes planes fly. So it's all about. So with the planes, obviously, as they go forward, they've got the shape of the plane's wing is something like that. So that as they go forward, the air goes the other way, right? And the air has longer to travel over the top part than on the bottom part. Sorry, can you see that? Is that okay? Yeah. Yeah. Because it's got further to go. If you look down at it, there's a little bit of attraction that happens as something flows over another surface, which means that it kind of sticks to it. And it means that you get more of a sticking effect on the bigger part of the wing, and that's what creates lift. So as long as you're going fast enough in a plane, it will take off because of the sticking effect. Now, taking that back to fluid movements, it means that if you've got an eccentric jet, as the flow happens, it kind of gets hugged to the wall, which means...
It stays stuck to the wall.
Yeah, so it stays stuck to the wall. And that's important because there's another way that we can assess severity with color, yeah? And that's the, what do we call it? It's like the jet area, thank you.
Jet area, yeah.
Yeah, so jet area, and what's severe?
So 40% or more of the atrium.
So greater than 40% is bad, and that only works if you're in the central area.
Yeah.
What's the problem with this? Why do I not like us to assess severity based on that alone?
Well, it depends on what you've got your Doppler settings at, and
it's all settings dependent.
Yep.
Beautiful. Give us another one. So we got eccentric. It helps us with eccentric versus central. The jet area.
Jet area. So color Doppler. So vena contractor, Pisa.
Nice. What's vena contractor?
Vena contractor's I'm going to have trouble describing this again. I have the picture in my head. It's the narrowest part of flow. So
beautiful. That's perfect. That's pretty good, right? So if you've got So if there was a horrible, that's the mitral valve, and there's the left atrium, and there's the ventricle. See if I can choose a better color. As the flow comes in, back from the LV.
So it should accelerate to the narrowest part.
Yeah, nice. So it's not actually, the narrowest part is not actually as you go through there. It's actually a little bit distal to it, to the regurgitation area. Oh, sorry, I've done badly there. So it's actually in there. Okay, not actually at the point there.
Yeah.
And what's severe?
Greater than 7.
7 millimeters.
Good man. And what's the problem with that?
Is settings dependent and operator dependent.
Depending on your aliasing velocity that you set.
Yeah, so absolutely. So that's all the settings. I'd say is also you need zoom, pre-processing. And I'd say that 7 millimeters, you know, we say the curve, it goes from like 4 to 7, I think, being mild to moderate and severe. I think it's pretty hard to make millimeters like that measurements. So I'd say the VC is small. Nice. Why don't we bring in this a bit later? Okay, pulse wave Doppler. Who's next? Thanks, Lewis. Cheers, man. Raymond. How can we use pulse wave Doppler to assess mitral regurg?
Pulse wave Doppler.
This is my fave. This is my favorite.
The pulmonary Doppler, the pulmonary veins will give you information. So the reversal, the severity of the pulmonary veins.
So normal is
S dominant.
S dominant.
D and A reverse.
S, D, and A reversal. So as you get increasingly severe mitral
S blunting first. S blunting versus reversal.
Beautiful. It's going to be blunted, and then if you've got good going severe, it goes the other way. Beautiful. And it's really nice. I think if you're not using this a lot in your assessments, just keep trying to use it. I find it really useful. It just often adds confidence to the diagnosis if you're worried about it, particularly if you've got sort of the eccentric jet and you can't get nice Doppler angles. If you can see you've got your S-wave reversal quite nicely, it helps point you to that you've got severe MR. Just blunting of the systolic wave, good for assessing, you know, raised left atrial pressure. The way I do it is you try and narrow your sector width down as much as you can. Get your depth exactly right. You've got to be really careful about getting aliasing, so watch out for the ghosts on either side of your pulse wave Doppler gate. I sometimes make the gate about 5 to 7 millimeters, so maybe a little bit bigger than normal. And you're keeping it as small as you can, obviously. And breath holding is sometimes useful, but it's something I do a lot and I like it. It can really help with assessing severity of mitral regurg. What's the problem with it, Ray?
So again, it's angle dependent, and if you have got an eccentric jet, you might not be able to catch it because it may only be seen in one of the pulmonary veins, and you can't necessarily interrogate all 4 veins. And it is subject to settings, like you talk about sampling volume, etc.
Yeah, nice. Angle dependent settings. And I reckon probably do it in about maybe 50 to 75% of patients if you're bloody lucky. I'm probably more in the 50 category. Maybe our sonographers are more in the 75. We got a couple of sonographers here who are really amazing at it, and I find it, you know, it can be a really useful thing to have in your assessment of these patients. Nice. What about another one? Another one that's good for pulse wave Doppler.
I mean, you can look at EA waves, but they're not particularly helpful.
EA, not quite. EA, but you're on the right track.
Well, I mean, about high E.
Yeah, nice. What's your cutoff?
I don't know. A meter.
Yeah, it's about 1.2 to 1.3. I might just quickly just show you a paper to maybe help with that. So I can show you what I mean. Can you guys see my screen? You guys okay? You can see my screen?
Yep.
Cool. I think it's this one. Oh. Sorry, guys. Oh, sorry, I can't find it. Yeah, it's basically they've done studies and it's got pretty good going sensitivity and specificity. About 1.3 is the cutoff. Sorry, I'll try and find that and send it around. What are the problems with that?
Well, there are other causes of peaked E velocities,
Such as
diastolic dysfunction or restrictive pathology. It is also subject to volume, so it's what's what I'm looking for. It's
flow dependent.
Flow dependent, yeah.
Nice, excellent. Cool. And the last one, who have we got next? Sid, are you there? How you going?
Yeah, well, thanks. Yeah.
Cool. Sid, help us. And finally, let's talk about continuous wave Doppler to assess mitral regurg.
Probably qualitatively, the density of the jet, which you see on the continuous wave Doppler, can determine the severity of MR.
Yeah, nice. So the jet density. And what's the problem with that?
Probably depends on the settings which we have, angle.
The continuous wave Doppler?
Yeah, I agree.
I think maybe it's more, I'd say, in terms of, it's probably more about angle dependent. Yeah, fair enough. Gain, actually. Yeah, that's a cool. Yeah, all right. So I'll take it back. Angle dependent. Gain settings. Cool. So I guess we'd say particularly that's the jet density. That's a problem if you're eccentric. So e.g. if you've got eccentric regurg. Yep. Gain.
As far as gain goes, though, you should be comparing it with the inflow, so it should be self-regulating.
So tell me what you mean by that. Tell me how that. So you're saying it should
so if
be.
You're looking, sorry, if you're using jet density with color wave and you're seeing a lot come through you're seeing a high density coming through the inflow, and then you've got a very low density.
Yeah, I see what you mean. Yeah, nice. Yeah, good comment. Yeah.
The gain setting doesn't matter as much.
If it's got the same density as the stuff above the line as below the line, that suggests you've got a lot of blood going both directions. Yeah, nice. Great comment. Yeah. I was also going to say the jet profile. So I guess a normal one would be a parabolic flow like that. If it goes in that, the cutoff sign with early equalization of pressures, so it ends before that one ends a bit sooner. So the early equalization of pressures, the cutoff sign, that can indicate severe. And big one.
Volumetric assessment with pulse wave Doppler.
Very nice, very nice. And how are we going to do that?
So we're going to look at the mitral valve inflow stroke volume and subtract the left ventricular outflow tract stroke volume. That will give us an approximate amount of regurgitant volume, and over 60 ml is severe.
Very nice. Did everyone get that? So comparing the blood flow going out of the ventricle, compared to what's coming into it. And if you've got the difference between the two of those, you can get the regurg volume. Ray, you're a cardiac anaesthetist, is that right?
Yeah, I am.
So you're probably going to be asked about this a lot. So I'm sure you get surgeons who, after they've finished doing their surgery, they want to know what the regurg volume is, assessing severity. Do you get that a lot?
So after a repair, you mean?
Yeah.
Yeah.
And how do you do it? Do you use PISA? Do you use how do you assess it?
If it's a repair, I assess it exactly the same way. So things like vena contracta, the size of the color jet, any blunting of the S waves. Hopefully, it's nothing severe, so you'll only be looking for blunting rather than reversal of the pulmonary veins. For any regurgitate, like obviously if it's a replacement, you're looking at paravalvular leaks, then you'd also want to describe how much of the circumference is occupied by the regurgitation on color. So that's a qualitative assessment, but you sort of is semi-quantitative. Yeah.
Fair enough. I think in terms of assessing actual regurg volumes and things, I reckon you've got PISA that you can do it. What are the problems with PISA? You can put it down here as well, because you obviously need the... Does everyone know what PISA is? I mean, it's not, I've got to be honest, it's not something I do a great deal because it's so bloody useless.
The PISA's angle, it's obviously you need the right settings, 40 centimeters per second. You also need, it needs to be central jet, it doesn't work with eccentric jets.
Nice.
And it makes a lot of assumptions about the velocity profile, which may not be true.
Yeah, so you've got your radius. The aliasing velocity is really important. The cheats way of doing all this is I always put the aliasing velocity so it goes down in the direction of which the jet's flowing. And so you move it down and put it on 40. And it works out some of it. If you've got it at 40 centimeters a second, the aliasing velocity, if you've got your radius that's greater than 1 centimeter, I think that's what makes it severe. Something like that. And as you said, lots and lots of assumptions. Assumptions plus, not great in CritCat. Nice. Cool. So try and do that in 12 minutes and you should be sweet. The big things for the exams, I guess, are people, the way you're going to lose marks, because often these aren't done brilliantly, these kind of questions, is, first of all, it's not being complete. You can't miss out a section. Try and be systematic going through it. I think, I have red flags that jump up for me if, people aren't mentioning the 2D. You've got to be able to smash this out, and you've got to be able to talk about the problems. And yeah, what else can I say is, particularly, you can't just write down, assess the mitral valve, assess the apparatus, look at the LV ejection fraction. You've got to give an explanation that goes with it. It doesn't have to be extensive, but if someone's asking you how you use echo to assess the severity of mitral regurg, you've got to say, well, I look at the jet area, and if it's greater than 40%, it's severe, but I know it's affected by the settings. If it's eccentric, I can't use it because of the Coanda effect. I'll look at the vena contracta, but I need to make sure I'm zooming up because it's a small number. I don't use PISA because it's rubbish and they're critically ill with too many problems. Pulmonary veins, and just draw it. I think you've got to not just say, I look at the pulmonary veins. You've got to say, I look at the pulmonary veins looking for systolic blunting or reversal, which is more severe. The problem with that is it's really hard to do. So that's why I think the table really helps. And just make sure you got one of these in your head for the mitral valve, for regurg, the same for stenosis, the same for aortic regurg, and the same for aortic stenosis. But to be honest, I don't think you'd get the severity of tricuspid regurg as one of the long answers, okay? All right. Any questions about that? Oh, sure. I'm going to take a picture and I'll see if we can put this up on the website as well. Cool. All right, let's talk about mitral valve prolapse. So who's next? Carton, tell me about mitral valve prolapse. So how do you define it? What causes it? How do you define it and what causes it? Oh, sorry, it's still on mute, bud. There you go.
Yep. So the specifications for defining prolapse are that the valve structures fall behind the level of the mitral annulus by at least 2 millimeters.
Yeah, nice. I had 5.
That's on a long axis view.
I thought it was 5. This is 2. Excuse me. Sorry about that. I think 5 may be suggesting it's more severe. Fair enough. Yep. What causes it?
And in fact, that's on parasternal long axis. I think the criteria are slightly different for the different fields. But strictly speaking, that's the definition. Causes. There are multiple causes. And one can break it. I suppose really I could just, one could highlight them by etiology. The commonest cause will be myxomatous disease.
Yeah, nice.
Which is a subset really of degenerative mitral valve disease, which is a poor name, which includes myxomatous and fibroelastic deficiency.
Yeah.
You can have non-myxomatous causes of prolapse that include things like pericardial or functional causes such as pericardial effusion and HOCM. You can have other causes which really involve failure of rupture or failure of the cords or the papillary muscle, so ischemic generally. But any other disease that will interrupt cord function, such as rheumatoid, myxomatous itself will commonly cause it.
Yeah. I think myxomatous is actually affecting the valve itself as opposed to these things which are sort of more apparatus. Yep. Yeah, nice. So you could, sorry, I spelled everything.
Yeah.
So I guess that's valve or apparatus. Beautiful. So particularly, I guess we're going to talk a little about ischemia, which I think is the one that would probably be most likely to come up in the exam because it's what we're going to see on that critical stage. Mm-hmm. And I guess if there was a question about prolapse in the mitral valve, it would definitely involve that table that we had before about how you assess mitral regurg. A second question would be along the lines of what numbers make you think it's severe? And the third question may be, if it's a prolapse, what's the difference between acute versus chronic? Yeah, yep. How to assess the severity. So just keep that in the back of your mind. Just in the meantime, we might just keep rolling. If we're dealing with ischemia, so talk to me about the apparatus. So we've got 2.
So you have 2 papillary muscles.
Nice, yeah. And what are they called?
The posterior medial and the anterolateral.
Very nice. So we've got...
And the posterior medial is supplied by the PDA, so 1 arterial supply but 2 heads, while the anterolateral...
Posterior medial. Yeah, sorry, cool, yeah.
The anterolateral has 2 arteries but 1 head, so it's supplied by either circumflex and LAD.
Yeah, so you got circumflex and LAD.
Yeah, and 1 head. So the posterior medial is more likely to suffer ischemia having a single blood supply.
Fantastic, and that's from the...
PDA.
Yeah, RCA, yeah.
Whichever is supplying the PDA.
Beautiful. So, posterior medial and anterolateral, single blood supply, posterior medial, hence more likely to rupture. And I guess the point I was trying to get to is that I guess this is more likely if it ruptures and flicks off completely, it's going to cause a flail. Yes. More likely. Whereas if you've got the circ and the LAD, you're less likely for that whole thing to, break off. But I think either of them can be affected, causing prolapse.
Yes.
Yeah. And tell me about where these connect to.
So they each supply the chordae, and the chordae from each papillary muscle goes to each of the 2 leaflets.
Fantastic. Really important, I think, that you've got connections that are to both of them from each of the papillary muscles.
Mhm.
All right. I think so if one breaks off, you can absolutely get a flail, but you do have connections to both. Got a beautiful picture I might just show you. I met a cardiac surgeon who also loves to take pictures of these stuff, and if you'll let me have 2 minutes, I'll just show you these pictures because they are absolutely stunning. So I think, you know, this is an example of the chordae. You can all see that okay?
Mm-hmm.
So here's this beautiful example of all the chordae coming off the papillary muscles, and I think are really beautiful about how they spread to both areas. You can see we had to sort of cut them off. So you do get the mitral valve leaflets up here. This is where the aortic valve is and the LVOT are, and how these chordae spread out to both areas.
Yeah, work of art.
Say again? I know, work of art is absolutely astonishingly beautiful, aren't they? So this is where the mitral valve is, and you've got, I think this is the anterolateral and posteromedial here, and so posteromedial seems to be affecting more the anterior leaflets, but there are certainly connections to both, and the anterolateral affecting predominantly the posterior, and again going to both. Really beautiful pictures, aren't they? All right. Yeah, nice. All right. Who's closest to sitting at DDU here? Who's sitting in next? Who we got next? Ravi, you there, buddy? Or Lewis? One of you two. Ravi, you ready to go? All right, Ravi.
Yeah.
I know only sent it around a few hours ago. Have you got that picture of the mitral valve? Do you want to tell me about how you're going to assess the valve leaflets? Can you hear me, buddy? Difficult to hear. Let me try and unmute you. Hang on a sec. It doesn't seem to be working. I'll tell you what, Ravi, should we let you off the hook just in the meaning of time? If we can't hear you, we'll work on it next time. Lewis, you ready? Do you want to give us a crack?
Yep.
Cool.
Yep.
Hang on, sorry. I've got Lewis Campbell. Not Lewis McLean, Lewis Campbell, excuse me. Yeah, cool. All right.
Oh.
Yeah, nice, yeah.
So that was the 2D assessment of.
Yeah, how about I just draw it? Yeah, so did you get the piece? Did you get the image that I sent you of the mitral valve?
Picture, yeah.
Yeah.
So
what leaflets are we affecting with the? So I guess what I was hoping to draw is you could draw the 4-chamber, 2-chamber, and 3-chamber, and what valves we're going to be affected. What valves we're going to do with each.
So the 4-chamber looks at the. I had this. I had it really clear. And 4-chamber looks it's got a long segment that goes through the medial and the septal, so A3 and A2. So it goes through 2 segments really of the anterior, and then on the other side it goes through P1.
Okay, how about 2-chamber?
And the 2-chamber goes through A1, and no, that can't be right. I had it as going through A1 and P1. No, that must be wrong.
No.
I'm going to find my picture again.
You're right. I find this really hard, and I think it'd be a great question to sit in the exam, ask you to draw it on there. If you're doing it on toe, it's a really good way to try and figure out. Really easy way is I just think about 0 and 90 degrees, and we'll show you a case in just a second. But if we remember our sort of toe picture, this would be the apical 4. Yeah? And remember, you get to your apical 4, you can get to your 2-chamber by rotating it sort of 60 degrees. I mean, I think in the textbooks they call 90 degrees the 2-chamber, and then this is your commissural view, yeah? And then this 120 would be your 3-chamber view, right? Or your, that's also the same for your, what do you call it, your parasternal long axis. So the big one for me is this one down here and this one here. So as you come through this, this can help tell you if you're looking at anterior or posterior. So you've got to remember that the lead, it's somewhere like that, the big smiley face. And then the other one to remember is your commissural view, which goes through P1, A2, P3. So I sort of remember looking a little bit like that. Okay? And then I remember that the, and should I draw it a different color maybe? Would that help? I know that my anterior leaflet is much bigger than my posterior one. So it looks something like that. You know, there's the posterior, there's the anterior. And so I can draw something like that. Can everyone see that? Beautiful. Remember it's 60 so that you've got, oh, okay. Something like that, I guess. So big anterior leaflet, smaller posterior. The next one I'll remember is that at 120, I'm obviously going through the aortic valve, and you're always looking at the right coronary in the aortic valve, left, and non-coronary in there. So as you were saying, when we're looking at apical 4, we're going through, so this is A2, where am I going to put that? A2, A1, A3, P3, P2, P1. And then you'd have a little, at 110 degrees, sort of going through there. That's where your left apical appendage sits. Okay? So if you're on a toe or you're on, you know, or you're on transthoracic, in your apical 4, you can pick up whether it's anterior or posterior quite easily. And then by fanning up and down, if we fan up, we get our 5-chamber view. And if we fan down, we get our coronary sinus. Yeah, is everyone with me? I do find this quite challenging. So apical 4-chamber view, fan up, 5-chamber, fan down, we get our coronary sinus. And that helps tell us if we're dealing with the anterior leaflet that's prolapsed or flail, or it's a posterior. And then from there, I then switch it around about 60 degrees, and that will give us an idea if we're looking at, sorry, A1 is, because I go through P1, A2, and P3. And if I fan that up and down, I can look at A2 or down into P2. Yeah? And then the last thing would be to come around to 120 degrees, and that's just going to be looking at A2, A1, P1, or A3, P3.
So that 120 degrees there is the sort of 3-chamber.
Yeah, exactly right. Exactly right. So when I talk about in toe, if my shirt is the toe probe, my patient's facing away from me and sort of sitting down, and I'm putting the toe probe down like that. My thumb is at 0 degrees, so maybe I'll do it like this, might be better. So yeah, that's going down their throat with their facing away from me, and that's 0 degrees. I have a little bit angled back for the toe, so I'm looking down at their heart, and then that's 0 degrees, 60, 120. So it's your thumb rotating round.
Yep.
So as I come in, apical 4-chamber view, there's a bit of a retroflexion. That gives me anterior posterior. And then I'll rotate around to 60, 90. And that gives me, I look for that leaflet where you get the two, coming up the two posterior, P1 and P3, and then you've got the A2 in the middle.
Mm-mm.
I think I don't think anyone's gonna, it's not pass or fail to get the cusps in the exam, to be honest. What is pass or fail is you've got to be able to assess the severity of the mitral regurg that comes on. I think you should be able to do this. I think you should be able to, I think it'd be fair to give you something in the exam, which was like the diagram that I showed you, and you'd be expected to realize that, the apical 4, goes through, so that way it's, because you'd be able to pick up anterior and posterior of the apical 4, and you should be able to figure out that the 3-chamber goes through the aortic valve. So I don't know, maybe I think it's a fair question, but I don't know whether I get it past all the other examiners, I'll be honest, but we'll see how it goes.
Okay. So, sorry, the 3-chamber view, you get the aortic valve and then you will see A2 and P2.
Yes. And again, you can move that. It's that, of course, it's going to be a little different with everyone. I guess this is just this is a picture I have in my head, and I'm sure people who are doing a lot of time must agree with me that sometimes patients just don't read the textbook, do they? And you're finding your apical 3-chamber view at 135 degrees or something. But I think that's about sort of what it is, I think.
So what do you see on the 2-chamber view on the toe?
Yeah, it's interesting. So I have, so again, for me, the 2-chamber view of transthoracic is at 60 degrees, because I go from apical 4 to 2 to 3, but they call the 2-chamber in transthoracic is typically at 90. So, I think if we stick to what's the commissural view, which I think is a classic one that we talk about at about 60 degrees, that's the big one that they love showing in the exams, going through P3, A2, P1. And, and if you've got a scallop that's jumping up at the top, that's A2. Yeah? There's only one view that you kind of get that in. And it's not really a 2-chamber. We've got a couple more minutes. Shall I do a quick case with you? So I might put that up just to see if that's useful for you on the website as well. Who's left? Oh, hi, Seb. We got Seb from New Zealand. Hey, mate. How's it going?
Still in Darwin, but yeah. Good.
Oh, I'm so sorry. I thought you were in New Zealand now.
Soon.
Excellent. Well, hi, mate. Hope you're going well.
Thank you.
Who would like to have a go at the next one? Who have we got? Should we go back to Lewis? Do you want to have a go at this case? Oh, sorry, and that's Lewis McLean.
Just trying to fix my internet.
Oh, actually, guys, it's probably a bit hard. You're doing it in bloody, Fiji. It's bad enough people doing it in Sydney. I don't know what's wrong with my internet, but should we start with Raymond? Sorry, maybe Raymond, is this really jumping for you?
No, it's fine. It's fine. So this is parasternal shot, long axis view, and it's focused on the mitral valve there. So I'm seeing a prolapse of P2. The anterior, the A2 leaflet there does not seem prolapse, but I want to put a cursor through that. I do not see a coaptation defect.
Which direction would you expect the regurg to be?
I'd expect it to be an anteriorly directed jet.
Very nice. I can't remember what I was messing around with doing these pictures, but what's going on with the color here? Why is it all weird?
Well, you've got this scale set more towards the blue than the red.
Yeah. So I completely balls that up. Yep, fantastic. What do you think about this image?
Yeah, so it's showing that it's got an increased ejection fraction, which is what you'd expect for a low resistance vent with a regurg.
So the raised ejection fraction. So do you trust this? What's wrong with this
This
method?
is consistent. So this is consistent with mitral regurgitation.
Do you trust the value though? What's the value? You got the ejection fraction. Do you know what it's called?
So this is the Tyke corrected formula using fractional error change.
So, guys, and what are the problems with that
using.
measure?
So what was that?
What are the problems with that measurement?
Well, it's only one dimensional, so it doesn't account for other values in a three-dimensional structure.
I just think if you're going to say it in the exam, and I think it's okay, it's a value, it's there, we can use it. I just think you've got to, particularly in the parasternal view, if it's one of the first cases, just make sure you don't let the examiner think that you're just going to trust that value.
Of course.
I think it's a really important point for all of echo. We talk about seeing the whole heart. And I think you don't trust one measurement for assessment of ejection fraction. I think you've got to use your eyeball, Simpson's biplane if you can, look at the stroke volume. And the same, I guess, with the mitral regurg, it'd be really important to say you don't just trust one parameter, you've got to put it all together.
So just with the module 3, just to clarify, I mean, do you get like the entire echo exam to flick through and get a couple of minutes to look at it, or do you only get 1 minute?
I wish. I'm trying, to be honest, I think that would be more realistic in real life. No, you don't. We've got 40 minutes. We're going to show you at least 5 cases, and that means that I get, maybe 5-7 minutes on average per case. And, hopefully we'll have, 8 ready to go. Very rarely everyone gets through all 8.
Right.
And it means that, we could just show you, I wouldn't, nowhere near as many as I'm just about to show you now.
Right.
And I find that quite challenging in terms of trying to figure out if someone's competent or not, I'll be honest. But so it'll be quick fire. You've got to be able to get that's what I'm sort of, as we're doing it here is similar to how it'd be in the exam, obviously a bit more formal and less swearing. But it would be, speak quickly and efficiently, and that at the higher function, so that the high level. What else are you seeing on this that you haven't mentioned? So you went for the ejection fraction. That actually wasn't the reason I showed this to you. What else is there?
Well, there's the ventricular septum, which doesn't seem particularly thickened. The leaflets and mobility, and the coaptation, I guess. So this is the M-mode through the leaflets, and if the leaflets aren't coming quite together. Yeah, good call. Yeah, exactly. I think it's showing on the M-mode, it's showing that there's maybe a bit of flail in there during systole. Good call. Excellent. So I think we're seeing that posterior leaflet is sort of flopping down maybe during systole. I was also thinking, looking at the internal diameter, it's 61 millimeters. Mm-hmm.
What do you think about that?
So it's enlarged, yeah.
Yeah, absolutely. So mildly enlarged, suggests maybe a more chronic picture that's, something's been there for a while. And to be fair, I think looking at this ejection fraction is probably somewhere around about the 65% mark. Beautiful. So what's here?
So this is still showing that P2 prolapse. It's very bulky and thickened. It does look degenerative. It does look myxomatous. The left atrium looks enlarged, but I want to measure it in systole.
Very nice. So what's this? What am I measuring here?
Well, this is a qualitative assessment of the MR jet severity, and you can see that the chamber is filled more than 40% on estimate of the left atrial size. There's a good demonstration of the eccentric jet Nicoenda effect.
Nice. And what's the problem with the measurement, the 40% thing?
Well, it's only qualitative, it's not quantitative.
Nice.
It is depending on your settings and appropriate velocity scale and gain settings.
Nice. Yeah. And eccentric nature to the jet. I think we've got a Coanda effect with it hugging that wall, which can mess up the jet area.
That's true. Yeah.
Beautiful. This is a pretty dodgy mitral valve inflow view, so I apologise, but I guess I'm trying to demonstrate. Just make you think about the E prime and the E wave, and if that E wave is greater than 1.3, it points towards severe. It's not an absolute. It's not perfect. It's not absolutely guaranteed, because I'm going to go on to show this is severe regurgitation, but here we can see that we don't have an E value that's greater than 1.3.
Yeah.
So just it's not perfect. And another example of how sometimes not all the parameters fit in, and sometimes those patients aren't reading the textbook. So what would you like to do next?
A toe.
Sounds good. Beautiful. Should we go on to the next one? Where are we up to? Carton, is this coming okay? Would you like to go through the toe with me? Are you able to see the pictures okay, or is it jumping around too much?
No, it's yeah, I suppose it's about 5 or 6 frames per second.
Not magic, sorry.
Yeah, no. So that's a mid-esophageal short axis.
Sorry, mid-esophageal. Just go.
Yeah, short axis.
So say it's a bit more in the gastric region for the short axis rather than the mid-esophageal. Because I think the mid-esophageal is more the four chamber, and then as you come down into the gastric, the plane sort of turns around and gives you that short axis. So I think it's for the short axis.
Short axis. Yeah. Excuse me. Yeah. Okay. Cool. I think it's at the level of the mitral valve leaflet.
Yeah, maybe a little bit down. Sorry, I wasn't perfect. Yeah. Just in the meaning of time. Oh, this is cool. So what's this view?
Bicaval?
Nope.
Sort of an inflow-outflow, is it?
Nice. Of what?
It looks like a bicaval of sorts, except the rotation is funny.
It's not a bicaval.
So it's inflow, outflow of something then.
I'm still in the gastric view, and I just went up to 90 degrees.
Is it the right?
Yeah, beautiful. It's the
right ventricle inflow, is it?
It's just quite a nice view that I guess it's often not in the textbooks, but you can sometimes get it in the gastric view. If you do some sort of anti-flexion, particularly in the deep gastric, you do some anti-flexion, and then you do some lateral movement. So you kind of got to twist the two buttons in the opposite direction, and it pulls up that probe and swings it to the right side, and you can get this inflow sort of outflow view. So here it's a way you can have a look at the tricuspid valve at the top. So there's the right atrium, and here's the right ventricle coming around the left ventricle. This lady's not perfect axis, I've got to say. And then at the bottom, it's the pulmonary valve. So it's quite a nice view that if you wanted to have a look at things like pulmonary valve acceleration times or right ventricle outflow, because I can sometimes find it quite hard to look at right ventricle function on toe. And so this can be quite a nice view to try and assess that. Maybe it's an aside. It's just like, I don't always get these pictures, so I think I stuck it in there. Let me show you that. So what do we see here?
Well, you're seeing I don't do toes, so you're seeing.
Oh, sorry.
Is that a mid-commissural view or?
No. So this is at 0 degrees. So
okay, so it's a fourth chamber then. From
0 to. Con, you're doing the DDU though, right?
I am, but I haven't done toes in 4 years. I've no machine, so.
You don't have cardiothoracics down in Wollongong, do you?
No, God no. So that's a four-chamber view, anyway.
We'll have to think about that. We've got to figure that out. So yeah, apical 4 or the 4-chamber view at 0 degrees in the mid-esophageal view. So which leaflets are we looking at?
So that'll be A2, P2, but very, very, very slight rotation can off-axis that.
And sometimes it's hard because, as I said, if you've got the valve looking, if you change the rotation or pull the probe up or down a little bit, you can actually start looking at A1, P1, or maybe even down into the A3, P3 region. I use this view just to tell me is it anterior or posterior, and then the next one is I flick around and I have a look at my, try and get the commissural view through that, and again you can use that angle backwards or forwards to try and see which leaflets you're in there.
Yep.
So here you can see a bloody great rip-roaring anteriorly directed jet.
From a prolapsing posterior leaflet.
Beautiful, beautiful. Don't worry about the PEDA. It's an AF, so don't worry about that. Beautiful. So this is about the 68 degrees because it's sort of the commissural view. So what do you think we're seeing there?
At 68 degrees esophageal. So well, I can see the regurgitant jet. I can see the
Nice. Which way is it pointing?
Anteriorly.
Other ways, that's going to be inferior. Remember, we've moved around 60 degrees, so it's sort of pointing more sort of in that direction now. Okay, and remember, this is on that side of the screen is the inferior, and the other side is the anterior wall.
Yep.
And it makes me think that we might be looking at maybe something like P1 prolapsing as well. Yeah. So again, it's not always just one leaflet that gets affected, one scallop that gets affected. Okay. Let's see if we find you. And this is me trying to sit at 90 degrees, just trying to fan through it slightly. And I wish I could slow it down, but what we can see is right at sort of the end of the loop is as I was fanning posteriorly. And I know it's posteriorly because you, if you're sitting at this value here in the commissurial view, you often get a break between them, right? There's got to be a hole in there. So you'd be seeing P3, A2, P1. Whereas in this one, right at the end, just about there, it all looks connected. Okay? And that sort of tells me that it's I think it's the P2 that's predominantly affected. And I think it's both this one, those two that are affected. Yeah? I'm sorry, Khan, to pick on you if you're not doing a lot of toe.
All right.
Yeah. And here we come round into our, sorry, that's still 0. And here we go, coming up to our sort of 3-chamber view. And what we can see is the aortic valve at the top, just sort of coming in. A2 that looks okay, which is this one here. And then the prolapsing one that looks like the claw is P2 that's going. Okay. Maybe, Khan, I'll just get you to have a look at one last thing. What's that and what does it tell you? This will be the last thing for the day. So I'll give you a clue. So up at the top up here, we've got the left atrium here, and we've got this little sort of appendix that
we're talking
out
about
there.
the pulmonary valve, and there will be a reversal of flow.
Nice.
Yeah. In air systole. So that's it
So
at the bottom.
reversal of flow during systole.
Yep.
Which is, and I'm particularly looking at the, for those of you doing a bit of toe, you'll see it's a sort of 48 degrees pointing more towards the left inferior pulmonary vein, which is what I was trying to hit with that eccentric jet that was sort of more inferiorly placed, showing systolic flow reversal. And I couldn't get all of them because it's bloody hard. Cool. So I guess, yeah, that's about it. Are there any questions? Clear as mud?
Yeah, I suppose the only question I've got is, again, a lot of this sort of subcategorizing which scallop is involved, I never do it. And I suspect no one else does either, except you.
No, I mean, I think...
maybe the odd person.
I think that's probably a bit unfair there, Khan, to be honest. So I think from a cardiology point of view, they're going to be really pernickety about this. You know, it makes a big difference for these surgeons trying to figure out how they're going to repair these things. So first of all, I think assessing the severity of it is really important because you've got to understand that if someone's got severe MR, even if they're asymptomatic, they've got a 50% mortality at 10 years if you don't do anything. I think if they are symptomatic, their 2-year incidence of having significant disease is again super high. You know, these are the guys that need surgery sooner rather than later. And if you're going to be talking to a surgeon, you've got to tell them what scallops are affected. So it is important. I agree, probably not from a critical care point of view. And that's why, as I said at the beginning, I don't think it's to be pass-fail in the exam. But you tell me you can't figure out if that with a prolapse, the limitations of all the standard things in terms of assessing severity, that's a big red flag to me that you're not competent. So, and I think if
I was asking really about the scallops, not about, I mean, severity, yes.
Sure. I guess from from an examiner's point of view, if someone can tell me about the scallops and may not be perfect, but they're sort of on the right track, it tells me that they definitely know about the regurgitation stuff. You know, I think if you know the scallops, you know echo, because it's really, really bloody hard. And so I understand your point, but I also think it's something that I'd love to put in the exam because it separates those who know what they're talking about from those who don't. And you don't have to be perfect, but you kind of got to understand a little bit, you know, tell me with certainty, you know, that's an anterior leaflet, that's a posterior leaflet. I sort of know that it's in the A2 region and the apical 4. You know, I may not feel 100% confident. I'm, of course, going to ask my colleagues for their help on this one. But does that make sense? I hear what you're saying, but...
No, I'm glad to hear that it's not a pass-fail, it's an additional bonus marks.
Yeah.
That's really all I want to hear, you know?
Cool. Yeah. All right, guys. Well, that's about it. Thanks very much for the week, and I'll put this up on the website shortly. Okay. So, thanks very much, everyone. See you next week.
Thank you.
Thanks again, Sam.